Hi, my name is Narelle Kirk and my airway management video will demonstrate putting a patient in the lateral side position, the safe insertion of oropharyngeal and nasopharyngeal airway, the use of the laryngoscope, triple airway manoeuvre, and positive pressure ventilation using the bag valve mask. Today is the 24th of September 2013. My student number is 2422585, and for the entirety of this video I'll be using standard precautions, gloves and goggles. Today I'll be demonstrating the triple airway manoeuvre, which is done to maintain the patient's airway patency. So positioning yourself behind the head of the patient and placing a 2 to 5 centimetre patty under their head to straighten out the curve of the airway. Placing your hand on the patient's forehead with your thumb pointed towards their nose and providing chin support with your thumb and forefinger. Gently extend the head and lift the chin. This is the head tilt and the chin lift combined, which helps to also maintain airway patency and displace the tongue posteriorly, and again just open up the airways. Then you place your outer fingers on the angle of the mandible, your index finger on the body of the mandible, and your thumb on the zygomatic, and push on the angle of the mandible to protract the jaw and maintain the airway that has been produced by the head tilt and the chin lift. A common error in this is hyperextension of the neck, which can exacerbate any spinal cord injuries or create a kink in the airway. Today I'll be demonstrating the use of the laryngoscope. So already having positioned myself behind the head of the patient and I'm in the triple airway manoeuvre, I have all my equipment on my right, except my laryngoscope, which is on my left. Picking up the laryngoscope in my left hand with my thumb pointing towards the end of the handle, checking that the light is on and intact, and then support the patient's head with my right hand and insert the laryngoscope in the extreme right of their mouth, keeping the tongue on the left. Observing the oropharynx at the moment and continuing to gently insert it down to the molecular groove, where I exert pressure along the axis of the handle and gently lift upwards to observe the vocal cords and observe for any obstructions. A common error in this is bending backwards, which can break the teeth or damage the larynx. Now I'll be demonstrating the insertion of the nasopharyngeal airway. This is indicated for the unconscious patient trismus, and contraindicated if there's a middle third apical fracture, significant nasal trauma, or a suspected neurological event with raised intracranial pressure. When doing this, you position yourself behind the patient and place them into the sniffing position, measuring the NPA from the nostril to the earlobe, lubricating it, and inspecting the nostrils for any obstruction and for the larger one. You then insert it posteriorly along the nose, rotating it clockwise and anti-clockwise until the length that you've measured is in. A common error of this is to insert it fully, despite measuring it, which will place it in the esophagus. You then look, listen and feel for breathing, and if a gag reflex is present, I'll be demonstrating the insertion of an oropharyngeal airway on the unconscious patient. Indications for this is if to maintain an adequate airway and to stop the tongue from falling backwards, or as a bite block. Counterindications for this is if the patient has trismus or an active gag reflex. It is important to choose the correct size by measuring from the corner of the mouth to the angle of the jaw, as an incorrect size, being too small, is ineffective and too large can damage the mucosa. In order to insert it, you insert it with the natural curve facing upside down, halfway, before rotating 180 degrees and continuing down until the flange is at the lips. It's important to make sure that the lips are not pinched in between the flange itself and the teeth. Once it is inserted, you look, listen and feel for adequate air entry, and if the patient begins to gag, then you remove it immediately.
Perfect.
So now I'll demonstrate assisted positive pressure ventilation using a bag valve mask. This is indicated for the non-breathing or inadequately breathing patient. Having positioned yourself appropriately behind the patient and having them appropriately positioned with the triple airway manoeuvre and an OPA if necessary. Using a C shape and grasping the mask with a point at the nose, rolling down and grasping the mandible, lifting upwards to maintain an adequate seal. Ventilating at 12 breaths per minute, approximately 10 mils per kilogram per patient. A common error of this is hyperinflating the bag, which causes hyperinflation of the lungs and can damage the alveoli.
lateral side position. It's used to maintain airway patency and to stop obstruction from the tongue or by aspiration. It is important to check for any dangers. Then positioning yourself at their hips, you move the arm that is furthest away outwards, the arm that is nearest you over their chest. You flex at the knee, you place one hand behind their hips and one of their shoulders, maintaining spinal protection if necessary, and gently rolling away from you. You place the leg forward and the hand beside the head. Gently extend and rotate the neck to allow free drainage of any fluids. Check for breathing and suction if necessary. A common error when doing this is to excessively rotate the neck, which can cause further spinal damage.